title of the session is Revascularization Challenges, the aortoiliac segment, and we'll start with a debate around treatment of task 2, C and D aortoiliac occlusive disease, endovascular versus surgical reconstruction, and we'll start with Mr. Zaid, consultant vascular surgeon at Guy's and St. Thomas's Hospital in London. Endovascular treatment should be the first-line treatment. Hani.
Thank you very much, Mr. Chairman, and again, many thanks to Professor Tah for the very kind invitation to be part of this exceptionally well-organized meeting. I remember when I started as a consultant, I had a very senior colleague called Peter Taylor, who he tells me that he's never lost a debate. So when I was asked for my first debate, I went to him and said, how do you win your debate? He said, you have to do 3 things, Hani. Number 1, you have to attack your opponent, you have to undermine them, and you have to prove that they know nothing they are talking about. Obviously, I thought I'm not going to do that. So with my esteemed opponent, Professor Abdelazim, I started Googling him, and this is what I found. And if you look at it, I wouldn't be sort of disheartened to believe that all of you will vote to this charming, good-looking, handsome vascular surgeon. This is particularly the case if the opponent is me. I'd probably vote for him as well. So despite changing my mind now, I thought probably I have to listen to my colleagues' advice and see if there is anything I can get on Professor Abdelazim to use as a weakness point where I can attack him in. So I've started trying to collect as much information as I could. And this is what I had coming back to me from my spies and sources. I've been told that he's an exceptionally capable and outstanding vascular surgeon. I'm told that anything will work in his hand. He was actually, just to make things even difficult, he was the external examiner of my MD dissertation. I found him very supportive and very professional. He's a very research-active vascular surgeon, and I'm told that he strives to deliver an evidence-based practice. So hopefully this was not what I wanted to hear. But just before giving up, I thought I will put the last statement to the test and see whether Professor Abdelazim will, I can manage to convince him with the huge body of evidence to support endovascular first approach. So I have no doubt that Professor Abdelazim will refer to this outdated classification, the task classification, because this is what suggests that open surgery should be offered to task C and D lesions. I have to point out 2 things. The first one is that this is a 15-year-old document, which means that it's completely outdated, it's not relevant to what we do now. But even with an open-minded, let's look at what it says. So for task C, it considers that if you have a bilateral external iliac stenosis, this is a task C lesion that these patients should have an open surgery. And I can tell from yesterday that the vast majority in this room will offer endovascular approach for those bilateral iliac stenotic lesions. So even if you look at task D lesions, when you have bilateral focal external iliac occlusions, this task document say that they should have an aortobiofemoral bypass, and I can comfortably claim that most of you here will offer an endovascular approach first. So it's effectively say that this is an outdated, it's completely irrelevant, and this is because we're increasingly looking after frail group of patients who are high risk with extensive comorbidities. And surgery has its own challenges as well, because those patients with previous surgery, it's a hostile abdomen, and we're increasingly seeing another type of hostile abdomen that we look after, and I'm sure that most of us will try to avoid doing an aortobiofemoral bypass on this gentleman. And because of these reasons, there has been an increasing popularity of endovascular approach, and this is an Italian 3-center registry looking at the outcomes in more than 200 patients, which effectively showed that the outcome following bilateral kissing stents, iliac stents, is equivalent to aortobiofemoral bypass. Michelle Reinen as well did a meta-analysis looking at the outcomes in more than 600 patients who had kissing iliac stents. And guess what the conclusion is? That the iliac kissing stent has safe profile and acceptable patency up to 2 years, even in task C and D lesions. And because of the high safety profile, clever people like Peter Govert, who we'll be hearing from later on, looked at even more complex endovascular procedure to treat more complex aortoiliac occlusive disease. And they published their 3-year outcome following CRAB. And impressively, they reported a secondary patency rate of 97% at 3 years. And because of that, we wanted to see whether this is just a one-off outcome. These are sort of very skilled group of surgeons who managed to get these excellent outcomes. So we joined forces with 6 high-volume centers in the UK. And we published our results in the Journal of Endovascular Therapy, including 116 patients who had aortoiliac reconstruction using the CRAB approach for CLTI or intermittent claudications. As I said, there were 116 patients. They were almost equally divided between intermittent claudication and CLTI. Interestingly, 82% of these patients were task D lesions, so they were not selected. These were all comers, and they were very complex lesions. And we managed to achieve a 3-year secondary patency rate of 92%, which is almost the same as the founder group of Belgium. And even we had a freedom from target lesion revascularization of 94% at 1 year. We even went further, and we joined forces with 12 other major European centers to look at the aortoiliac reconstruction, whether this is using covered or uncovered stent. And we managed to recruit 252 patients who all had aortoiliac reconstructions. Again, if you look at it, 78% of those patients had task C and D lesions. So again, the complex group of patients that the tasks say they should have open repair. And we had a freedom from target lesion revascularization of 90%, with marginal benefits if you use covered stent. And this was published in the European Journal of Vascular and Endovascular Surgery as an editor choice. Even to convince Professor Abdelaziz more, we did a further meta-analysis, and in this meta-analysis, we looked at 66 studies which looked at the outcomes in patients who had either endovascular repair or open reconstruction for aortoiliac occlusive disease. This meta-analysis included 9,319 patients. Most of them had open repair, but there's a big portion of them who had endovascular repair. And there was an obvious early advantage for endovascular repair when it comes to 30 days mortality and 30 days morbidity. And despite the fact that open repair had a better primary patency rate, what matters really, the secondary patency rate was not different between open and endovascular approaches. And that's why, in the latest recommendation from the European Society of Vascular Surgery and the European Society of Cardiologists, if you look at their algorithm and flow chart, the aortoiliac lesions, if you have an isolated iliac lesion, it doesn't matter whether this is unilateral, bilateral, occlusion, or stenosis, they should be offered endovascular approach first. It's only if it extends to the common femoral artery, they didn't even consider open repair. They said you treat them with hybrid revascularization, meaning femoral endarterectomy and then endovascular recanalization of the aortoiliac segment. And that's why if you now, I hope that I managed to convince you that if you find or you face a patient like this with aortoiliac extensive occlusive disease with some important branches that you would like to preserve, I hope that you feel that with the available technology, the improved approaches that we have, we can offer them a very safe endovascular reconstruction, which preserves the patency to the limbs, preserves the patency of all the important branches, and it's durable as well. So in conclusion, Mr. Chairman, ladies and gentlemen, Professor Abdelaziz, I think based on the available evidence that endovascular approaches really have an early advantage in terms of morbidity and mortality over open repair. And when it comes to secondary patency, there is no significant difference between the two approaches, open or endo. And that's why I think endovascular technique should be the first line treatment for task C and D lesions. Thank you very much for your attention.
Thank you very much indeed, Mr. Zaid. Next is Professor Abdelaziz will argue for surgical reconstruction should be the first line treatment in task 2 C and D aortoileal occlusive disease? Dr. Tariq.
That pointer. Thank you, Mr. Chairman. It's very hard to respond after an excellent presentation from Dr. Hani Zaid, but I will still try to defend the surgical option. So this is the type of patient that we're talking about, total aortoiliac occlusion, and the options here are either to do a standard, straightforward aortobifemoral bypass, or try hard and long to pass a wire up this long lesion and then dilate it one way or the other, put some stents in, and so forth. Let's look at some data. Not all the data supports both approaches. This is a study from 2016 looking at aortoiliac reconstruction by kissing stents versus aortobifemoral bypass. And they showed clear difference in patency at 5 years between the two groups, with a higher rate of re-intervention to achieve that patency with the endovascular group. And furthermore, the authors in their limitation of the study section acknowledge that they tended to shift the patients with more complex lesions to the surgical arm. So they're all type D lesions, but as we all know, not all type D lesions are the same. So there was some form of selection bias for these patients. Another set of data came from the so-called CHAOS registry. It's an Asian registry, and again, they looked at aortobifemoral bypass versus various forms of endovascular reconstruction, 384 patients, and showed a significant difference in patency over 5 years between the surgical and the endovascular group, as well as a better survival rate. Another interesting study that was published this year in Annals of Vascular Surgery, again comparing the endovascular versus open surgical approach. And before I tell you the results of this article, this statement again shows you that there's always a little bit of a selection bias. They only included aortobifemoral bypass patients if they were considered suitable candidates for the endovascular option. So if they were more complex and not suitable for the endovascular option, they were excluded. So there, again, there's some form of selection bias here. But nevertheless, they were able to achieve only 50% 5-year patency versus almost 90% with the aortobifemoral bypass, better survival with the aortobifemoral bypass, and concluded that it is a viable option, the endovascular option is a viable option for management of TOSC2D lesions, lower morbidity, and, quote, acceptable durability. And I'm not sure why you would accept a 50% durability when you have another option that would give you almost 90% durability. Other important issues have to be considered. This is a very important article that was published 2 years ago, showing that younger patients do worse with the endovascular approach compared to the open surgical approach. And they looked at the Vascular Quality Initiative data set, over 5,000 patients, and split them into below and above the age of 60, and found that there was a significantly increased rate of major adverse limb events as well as patency for the patients who were under the age of 60 if they had an endovascular approach versus an open surgical approach. And so they concluded that for such patients under the age of 60, you should offer them as the therapy of choice, open surgical intervention. Another important issue is the indication of your procedure. If you're doing it for claudication, then you should read this paper by Bath in Journal of Vascular Surgery last year, where he concluded that endovascular interventions for claudication do not meet the minimum standard for the SVS efficacy guidelines. Why is that? Again, they looked at over 16,000 patients from the Vascular Quality Initiative, and they found that if you're doing an aortoiliac intervention for a claudicant patient, only 37% of them will be free of recurrent claudication at 2 years. And if you add to that a FEMPOP intervention, that rate drops to even 22%. Only 22% will not have recurrent symptoms at 2 years. The minimum SVS efficacy guidelines requires at least 50% to be free of that. So the endovascular procedure did not meet those requirements. Now, the advocates for the endovascular approach will tell you that we do not burn any bridges. So start with the endovascular approach, and if it fails, you can always come back to the aortobiofemoral bypass. And there's a lot of data to support that this concept is really not true, at least not in all cases. This is, again, an important article that was published last year showing that prior endovascular intervention are associated with a higher complication rate and a lower patency rate of a subsequent aortobiofemoral bypass. So if you do an aortobiofemoral bypass following an endovascular intervention, you get lower patency and higher complication rate, as shown on this graph. Another paper supporting the same concept: prior endovascular intervention negatively impacts morbidity after aortobiofemoral bypass. So the concept of not burning bridges is really not true. The odds ratio was 2.2. Yes, this is a patient that I saw in my office just 2 weeks ago who's had this procedure done somewhere and then came with critical ischemia, severe rest pain, gangrene of the toes. And now, as you see here, the stents go all the way up to the SMA. He has occluded, sorry, the pointer is not working, but he has occluded his right renal artery. The stent is up to the SMA. So now, to do an aortobiofemoral bypass, you have lost the infrarenal aortic segment, you have lost the juxtarenal aortic segment, you're forced to go up to the celiac segment or even the lower descending thoracic aorta to do your aortobiofemoral bypass. So you certainly have burnt some bridges doing such a procedure. Let me just remind you that aortobiofemoral bypass is not the only surgical option. This is a very interesting article that just published in the JVS of this year, reminding people of the aortoiliac endarterectomy, the lost art of endarterectomy. It's an excellent procedure. If you do it properly, for a properly selected patient, you get excellent patency. And again, the good old ex-bifem bypass, I think, is still suitable for patients who are not good candidates for a major abdominal procedure. So what does the guidelines tell us in face of all this data? This is the global guidelines. I agree with Dr. Zaid 100% that the task is now outdated, but this is the global guidelines of 2020, and they actually kind of left it open. They suggest that you can do endovascular or open surgery as a first line of treatment, so they're leaving it up to you. Suggest means it's a grade 2, not 1. But then they go on to say that if you have, if the endovascular intervention potentially would impair a subsequent aortobiofemoral bypass, then it should be avoided. And I just don't see where would the endovascular intervention not interfere with a subsequent aortobiofemoral bypass, as we have just seen. And then they go on to recommend direct open surgical reconstruction for reasonable surgical risk patients, patients who are not amenable to endovascular therapy, patients who have failed one or more attempts of endovascular therapy. And again, I'm not sure how many failures do you need to go through and put your patient through before you finally decide to do an aortobiofemoral bypass. And finally, if you have combined occlusive and aneurysmal disease. So I would just like to add to that, based on the data I just presented, younger patients should be offered the surgical option. Claudicants, as we have seen, are not well served by an endovascular option. And please remember the cost issues. The CRAP procedures with so many covered stents put in are very expensive. We all know that we are going through very tough financial times. So next time you get a patient like this with total aortobiiliac occlusion, you can do this, of course, put so many stents in and probably end with something like this shortly thereafter. Or you can go for the gold standard aortobiofemoral that stood the test of time with a 5% complication rate and excellent 5-year and even 10-year patency. And I just thank you very much.
Professor Abdelazim, thank you very much indeed. Could I invite both Mr. Zaid and Professor Abdelazim to the floor, please? Well, I've only got a couple of questions here. The first one is to Hani. What about age, Hani? Does it come into the equation at all? Does it matter?
It does in the context of how does in the context of how the physiological status of the patient is. So young patients who physiologically are old, we don't count them as young. It has to be the full picture. The cardiovascular risks that these patients have, the renal comorbidities, the mobility status, and all of that. So it's not just age that matters. I know that Professor Abdelazim made a very good point about young patients. If they are young and fit, you probably will not have any peripheral vascular disease symptoms. But otherwise, if they are young with heart failure, ischemic heart disease, and so on, probably they will be better served, in my opinion, and according to the evidence, with endovascular.
Well, the next question is somewhat relevant to that. Professor Abdelazim showed us an angiogram with stents all the way up to the level of the renals, even the SMA. How proximal would you allow your intervention to be?
Sure. So it always, and I think this is to some extent a benefit of having some surgical insight into the endovascular planning, in that we usually have enough space for infrarenal clamping, so we don't go above that. But I have to go back again to the title of the debate. It's task C and D. And my esteemed Professor Abdelazim, these cases are actually outside of task classification, because if the occlusion goes to the renal artery, this is not what we're talking about. Yep. And certainly, in my practice, yes, open repair will be the right thing. But the task C and D we're talking about, as it's shown in the document, it's a very focal and localized aortoiliac. It doesn't extend to the renal arteries. If it does extend, then this is outside the remit of the task.
Thank you. A couple of questions for Professor Abdelazim then.
I just agree completely with what he just said.
Sure.
Yes, if you go up, then you go for the surgery. If you have a focal lesion, sure, why not try the endo-option first?
Would you offer an aorto bifemoral bypass to a claudicant if they are morphologically suitable for an endovascular intervention?
If it's a straightforward endovascular intervention, then I would offer that. Yes, yeah. But if you have total aortoiliac occlusion, task D, then yes, I would offer the aorto bifemoral bypass.
Okay, you've talked about endarterectomy, aortoiliac endarterectomy. Do you have a gender bias towards who to offer this intervention for?
Yes, definitely it's not very good for females because of the size of their arteries. But I think it's a good option if you have a large-sized aorta that's occluded, and you, Professor Abdelader Ott has actually got a very nice series for the aortoiliac endarterectomy, and he's shown me some excellent angiograms of how he used to do this procedure at some point. So it is a nice procedure. It needs very good patient selection, as outlined in this article. I think it's a very interesting article published this year that I would recommend for you people to read it. And if you properly select the patient, if you do the procedure right, you will end up with a very nice long-term patency, and you have not put any prosthetics in the abdomen as well.
Thank you. Well, I have got no more questions on... Oh, my co-chairman would like to ask a question.
Professor Tarek, thank you for this presentation. But I asking you, do you prefer to do end-to-side or side-to-side anastomosis in aortoiliac?
We used to do end-to-end first when we were trained to do that procedure, but now we almost always do it in an end-to-side fashion because it's better for the pelvic circulation.
Thank you
very much. And it doesn't really make a big difference as far as hemodynamics like we used to think.
Thanks very much. Dr. Ashraf, tfadal.
One of the big problems for endovascular management of aortoiliac disease is the wire going up and the section up to the renals, and it happens in many cases of endovascular repair, and it is a real hazard because it's going to end in a catastrophe. Can you tell us what's the size of this complication, and does it give you a warning that you should go to aorto bifemoral?
Obviously, yes, this is a scary complication. So we always give ourselves around 1.5, and we'll hear it from Peter later on, 1.5 centimeter above the bifurcation. We try not to break back in any higher. And if we can't, we have to come either from the arm or from the other side. We try to play it safe because the whole idea of it is that you're trying to help someone, but not by adding another complication. And if we dissect and lose the renal, we're talking about a completely different... So we try as much as we can not to reach this stage by using all other tools or different accesses.
Thank you very much, Hani. I think we're running out of time, so it's time for voting now. So could I invite everybody to vote in this debate? So Mr. Zayed argued for endovascular reconstruction as first-line treatment in task 2 C and D lesions, while Professor Abdul Azim argued for surgical intervention as a first-line strategy. بالتالي تسكان التليفون أنا للأسف تليفوني مش معي. Well, it doesn't seem that Peter Taylor's advice is working. So option two is the open. Okay. So it doesn't seem that Peter Taylor's advice worked. Well, thanks very much, both of you. Well, we now move on to the first talk in this session by Professor Peter Goverd in Belgium. And Peter, can you hear us and are you with us?
Yeah, Mr. Chairman, I hope you can hear me.
Yep, okay, fair enough. Well, the floor is yours, and you're going to tell us about CRAB and chimney CRAB, my algorithm, tips and tricks.
All right, thank you very much for the invitation. We had already two fantastic talks about the treatment of aortoiliac disease. So these are my disclosures. So most important is, so now I want to have it about a few items like diagnosis, workout, patient selection, and so on. So first of all, and Hani made that very clear, what we're talking about is especially the aortoiliac disease. So meaning it's not only aortic or only iliac, it's a combination of distal aorta and iliac disease. So that's the region where we actually are going to treat the lesions. So additional information is, so in the beginning, we tried to do our endovascular reconstructions with putting in stents higher and higher. And I did, let's say, the same in the dummy. And you can actually imagine, try to find this in the human body. I can assure you this will fail. Yeah, the same like this sort of reconstructions where the stents are going higher and much higher than the bifurcation. You can see here that you already go higher than the last lumbar pair of arteries. So also there are a lot of publications already available that when you put in kissing stents to deal with aortoiliac disease, that there are a lot of items or topics that could jeopardize your outcome. So that's the reason why we actually created the covered endovascular construction of the aortic bifurcation, or shortly the CRAB technique. Yeah. For the moment, there are, let's say, 5 different balloon expandable stents on the market where you could create a CRAB with. Yeah. I don't know if in Egypt everything is available, but even in Europe, we don't have the availability of everything. So first of all, and this is also mentioned in the previous presentations, diagnosis is also, the diagnosis in the workout is always very, very important. And I think we'll go very fast about it. So of course, physical complaints, examination, and so on. So during your diagnosis and the diagnostic workout, you need to find out which task classification is C, D, the extension of the disease, is it calcified or not, combination of the lesion, involvement of visceral arteries, what is with the collateral circulation, and also what's important is what with the outflow. Yeah. In case of stenotic or occlusive disease or a combination, so stenotic, then an interval of interluminal recanalization is most very possible. Where occlusive, you will probably go to the subintimal space. Same is it calcified or not, or have we a soft plaque or a combination? Also, that will have an impact on, let's say, the decision of the treatment way, and also which material you want to use. What I said, very important is also the collateral and the collateral circulation and visceral artery involvement. Yeah. So for aneurysmatic disease, we don't care. Yeah. We sacrifice mostly the inferior mesenteric artery, but we know that the inferior mesenteric artery and also the hypogastric artery are crucial sometimes in case of collateral circulation. There are a lot of very good publications and presentations on that topic. So it's so important that you actually recognize and find the collateral pathway that is actually being used by your patient, depending it's a C or D lesion. Yeah? So you need to understand the different, like you see here in the examples, you need to understand the different pathways of collateral circulation, and then you need to try to find out which of the different pathways are actually being used, so that you know in advance which arteries you cannot sacrifice, or you need to be very careful not to sacrifice. So it's not only for endovascular, it's also for classic surgery, but it's especially for endovascular surgery very important. Yeah. When talking after the collateral circulation, the same with the outcome of the aortobifemoral prosthesis is the outflow. So you need to see that external iliac, common femoral, deep femoral, superficial femoral, what's the situation? What we mostly do in case of a combination of common femoral calcification or femoral bifurcation calcification is a femoral enterectomy, with a patch on the common femoral, and doing then our endovascular reconstructions. Also in case of common femoral and deep femoral lesions, especially the superficial femoral artery is not so important. So the most important is, of course, the deep femoral artery. So also what was mentioned in the previous presentations, patient selection, again, task D and C lesions. And I think the most of those patients that actually can be done with syrup are patients that are in the yellow markings. So you need to avoid going in the infrarenal or the juxtarenal region. It's possible, of course, you can actually do it chimney syrup, but still, I not completely believe that is the most optimal, or could be the most optimal situation for your patients. Yeah. Also, you need to see if a double barrel reconstruction or another bifemoral prosthesis, like I mentioned before, could be a better solution for your patients. Mostly our patients are at least 50 years old. Sometimes they are younger, but then they are having a physiological or anatomical age that are actually around 70 or 75. So mainly patients who are unfit for surgery, and where an endovascular is a first option. So mostly in obese, patients with previous abdominal interventions, multiple comorbidities, and older age. So this is mostly my algorithm in case of type D. Infrarenal aortoiliac occlusive stenosis, depending on the histology of the plaque. So in case of it's completely soft plaque, mostly I do a double barrel, sometimes a double barrel kissing covered stent reconstruction. It avoids a lot of displacement of soft plaque. In case of mixed plaque, so when the proximal part of the proximal half is being made of soft material and distal part is calcified, we mostly start, it depends on the thickness of the soft plaque, to, let's say, fix the soft plaque with the deployment of a large self-expandable closed cell stent that actually place the plaque to the aortic wall, and then finishing with a traditional syrup. When the proximal part is calcified, distal part is soft or calcified, we mostly do a syrup. In case of completely calcified plaque, our first treatment option would be syrup, or in case a large IMA is involved, a chimney syrup. So in case of small aortas, recurrent disease, or on different indications, we do still surgery. We are still surgeons. Also very important, and I think everything is as important as the operation itself, is the pre-op preparation. So again, examination, CT, 3D reconstructions, measurement sizing, what material do you need, do you want to need, what could be the problems, and how can I avoid problems, what is the solution for the problems, and so on, and so on. So it's like a difficult EVAR, So this is one of the plannings, or different plannings for a syrup. It's not just putting a few stents in an aorta. It's really like a real EVAR. So what we do, we actually make a complete workout before we actually start. Choice between syrup and chimney syrup. So most important, is there a visceral artery involvement? And then mainly for the inferior mesenteric artery, lesser in the renal and SMA, but mostly the inferior mesenteric artery. Also, what is very important, always check the SMA, because sometimes you see that also the SMA can be stenosed, or can be having lesions. So if the SMA is stenosed, and all the IMA is larger than 5 millimeters, we always consider a chimney. Of course, with treatment of the SMA in a first stage, if that's possible. In case of renal involvement, and there is no way out, there's no other solution, you could consider chimneys, but then you need a brachial access, either uni or bilateral. We did a few, but this is mostly not, as Hani already said, this is not the first option. This is a case example where actually the renal artery comes very low. So just to rehearse the syrup step by step, mainly is aortoiliac bifurcation and proximal of that lesion. So, sorry. First of all, we put in a 9 French introducer in the best of the two, putting on the all upwards to the above the lesion, then, sorry.
Peter, we're running sort of close to time, so I would ask you if you would be so kind to try and finish. Thank you.
Yeah, no problem. So, yes, all right. So, mainly what is very important is your workout. And as Anya already said, recanalization is also very important when you go, if it's not possible from below, then you go from above, meaning that you need to take also, if you use a brachial artery. So also that is very important. And so in conclusion, so the stirrup is still, I think, in my opinion, a very good alternative to treat autoiliac occlusive disease type C and D lesions. Yeah. We did now almost 200 patients without major complications. So the midterm results, our 3-year results are already very good. 5-year results are coming shortly, or will be published shortly. We still need to have dedicated devices. Yeah, I think that's very important, and also that will reduce the material costs, and also for then the chimney syrup. It's also a very good technique, but you need to know what you're doing, yeah, and for what reason you will do it. Right? It's a much more complex procedure than a syrup, yeah, and short terms are very promising. Long terms, we still need to see how they do it. Also here, maybe low profile and adapted dedicated devices are needed. So I thank you very much for your attention.
Thank you very much, Peter. Could I ask you to stay with us till the end of the session, Pete? We're going to save questions till the end, if I may. And if I can now introduce Professor Konstantinos Stavroulakis. I'm so sorry if the pronunciation is not the right pronunciation, but Konstantinos is going to talk about salvage of failed endovascular aortoiliac reconstruction.
So thanks a lot for the kind invitation. I'm happy to be here because, like being somehow back to the roots, my great-grandmother comes from Egypt, but it's for me the first time here, and thank you very much for the invitation. So I think we heard a lot from both from Hani and Peter about aortic reconstructions, and all of us use in our everyday practice both kissing stents and the syrup technique for aortoiliac reconstructions. Both of them have advantages and disadvantages, like every technique in surgery. And what we know from the COBRA registry, and I think Hani showed the results before, is that the rate of TLR, of target lesion revascularization, after both bare metal stent and cavern reconstructions are not that high. We talk something about 20% after 36 months. Which is, I think, a very acceptable number, given that the majority of the patients that were included in this trial were patients that had task C and D lesions. Most of them were calcified with chronic total occlusions. But still, we need salvage procedures. And how do we understand salvage procedures? First of all, in the acute setting, when we have some acute failures and then technical problems which require troubleshooting, and then chronic failures when we most of the times have a progress of the disease. And progress of the disease can be easily solved. We see in this case a patient coming back with in-stent restenosis was placed just a covered stent to cover the in-stent restenosis. Of course, this is a kind of disease that we can treat in our everyday practice. It's easily performed from, in this case, transbrachial access because of the hostile groin and so on. But most of the times, this is not the case. You have much more complex disease to treat. But what I want to say, and what I want to focus on, is that when we treat the patients good and properly from the first time, many times we'll have to avoid this kind of salvage procedures. You see here a patient treated with an EVAR for an aortic aneurysm, and you see that the patient developed at the end of the stent graft an edge stenosis. So the colleague that tried to treat the patient wanted to avoid to stent the aortic bifurcation. The reason is that, of course, when we have double barrel constructions or even syrup reconstructions, we cannot go up and over for the future. We talk about a patient that has a AAA and a PAD, so in this case, the colleague thought that it's better not to stent the aortic bifurcation. So he performed a double kissing PTA and afterwards placed the bare metal stent, the Luminex from BART, in order to save the future of the options of the patient. But then the patient came back again with a restenosis and edge stenosis, and then we used a dedicated device which was then introduced for the aortic bifurcation. It's from Andramed. It's a German company which has a double, which has a nip like a Y shape of the stent where you can use it and place it direct in the bifurcation while being able to go in crossover technique. But the question is, did this patient will require this salver procedure if we have gone for kissing stent placement from the beginning? Because when we try, sometimes I think that when we try to, we create more problems when we have not the proper treatment from the first time. And restenosis is something very common also for open repair. And you see here the patient that has an aortic bifemoral bypass that developed a stenosis distal of the anastomosis. It was performed atherectomy and was treated quite well. So a progress of the disease, something that we can expect because these patients will develop again and again atherosclerosis. But the question is that if this patient will avoid these TLRs, these secondary procedures, if we treat the patients properly from the first time. And what I mean from the first time, this is a very difficult situation to treat. You see a patient treated with covered stents, kissing stent technique for a very calcified iliac disease, and the stent didn't expand. So the patient comes back, he has an instant restenosis, but not because of neointima, but he has an underexpansion of the stent. So how are we going to treat this situation? I tried to post-dilate the stent, placed another covered stent inside, but still the stent cannot expand. And the question is, would we have these kind of problems if we had treated the patient properly from the first time? So now we have more and more, of course, endovascular materials. Sometimes we can even use for the iliacs or the aortic disease intravascular lithotripsy, better covered stents with greater radial force, and so on. So from my point of view, these kind of complications would have been avoided if we had used a proper stent or a proper treatment for the first time. And again, when we go back to acute problems, some acute problems and the way we treat them will cause many problems also in the future. You see here a patient coming for actually an iliac CTO. The colleague tried to recanalize it from transfemoral access, completely subintimal recanalization with dissection. He didn't even think that he was in subintimal space, performed an angiography, and you see you have a long dissection of the infrarenal aorta. And then try to solve this problem by placing a 6 millimeter ICAST in the right iliac artery, which is, of course, completely undersized. The problem is that these patients come again and again. And it is not only that we have here a very undersized stent, but also the dissection was not completely covered. So then the stents were prolonged in the infrarenal aorta with also a with a bare metal stent in the external iliac. But you see that we still have a 6 millimeter stent in the iliac artery and also in the distal aorta, which is completely undersized. And this is something that we cannot really salvage. And this patient will come again and again with an occlusion of the stents because it's completely undersized. And at the end of the day, we can try to solve everything endovascular, but this is not possible. And what we did after repeat intervention is that we performed an aorto-bifemoral bypass as this patient would keep coming again and again with occlusions. So again, we see a patient that came back. He needed a salvage procedure just because the initial treatment wasn't done properly. Going back to troubleshooting, I think this is a situation that happened to most of us, at least to me sometimes. dislocating a stent in the aortic or aortoiliac bifurcation. We all know that the bare metal stents, the balloon expandable stents that we use for aortoiliac construction sometimes can be dislocated. You see here that while trying to go up and over with a sheath, I dislocate, complete the stent, I have to place another one to solve this problem. And of course, we have to be very careful. After this case, I am very careful on my own. And you see here that even with, in a very easy lesion, we don't talk here about a challenging task D lesion, just going with a sheath, you can dislocate the stent and need excessive troubleshooting. We heard a lot about the serap technique, and I want to show you troubleshooting during a serap procedure and how things can go south even when you do or try to do everything properly. This is a patient coming with an aortoiliac reconstruction. He had excessive he had a hostile abdomen. That's why we decided to go for serap reconstruction. The recanalization was quite easy, combined from upper access and open surgical exposure of the groins. In this case, we go for a hybrid approach. We perform an open exposure of the groins, perform common femoral endarterectomy, and retrograde disobliteration of the external iliacs, and then we just treat endovascularly the aortoiliac disease. First of all, of course, dilation of the aorta and the iliacs. We try to create some channel for many lesions. First of all, because the serap technique will require a big sheath, we have to go up to the aorta with a 12 French sheath, in this case while using the big graft aortic stent graft. And as you see here, after repeat angiograms, we advance the aortic stent in the aortic, in the distal aorta, and then trying to balloon it, as you see here. In this case, I'm not sure if you have experience with a big graft aortic. It's a very good stent device, a very good graft. Nonetheless, the opening of the graft is quite challenging. You have to wait a bit. The balloon has a shoulder of 50 millimeters, which means that you have to go 50 millimeters above the aortic bifurcation, and then we completed downwards with the two cover stents. In this case, are big graft plus stent grafts, and then post-dilate them. You see here that we extend the reconstruction to the iliacs with covered stents up to the groin. So up now, it was the time of excitement when I thought that, we can treat everything, almost everything endovascularly. This is an occlusion going up to the renals. I was very happy, very excited. And, this is the moment of excitement that everything goes south. And just to be honest, this is a case that we have to be very careful. The thing is that, and I'll show you afterwards what was the big mistake that we have done, is that we didn't check after placing the iliac stent that were in the aortic stent. So practically, we deployed the second iliac stent behind the aortic stent graft. And this is something that we didn't notice because of the moment of excitement. So this is a common failure that you can do also during a NIVA procedure, but this is something we didn't notice. So when we performed the diagnostic angiograms, somehow we didn't have any flow on the left limb, and we were wondering why we have an occlusion. And then we performed an angiogram in the left limb, and when we saw and we realized that we're behind of the aortic stent graft, and then we have to extend the left limb, the left coverage reconstruction up to the renals, and this is of course a disaster. And this is something that this is something that happened because, as I said, it was a moment of excitement. Afterwards, we have to extend the reconstruction up the renals, and you see that at the end of the day, we end with a kind of kissing stent reconstruction up to the renals, which is hemodynamically a disaster. Of course, we salvaged the procedure during the case, but at the end of the day, this is something that should not happen, and open repair would have been better for this patient. Last case about troubleshooting aortoiliac CTO. trial to cross from above and transfemoral. As you see on the left-hand side, while crossing from above, I lost the left hypogastric artery. That's why I decided not to lose the right hypogastric as well during the canalization, go for aortoiliac reconstruction with a chimney for this inferior mesenteric artery, perform the chimney reconstruction, and I'm not sure if you can see it very well. In this segment above the reconstruction, we have something in the angiography that wasn't really clear. And I thought that's just an artifact or something that doesn't really influence the reconstruction. But the patient occluded again 24 hours later. And you see here that the patient developed again acute lip ischemia with a complete occlusion of the reconstruction. So we went back to the OR, performed an open thrombectomy, extended the chimney graft and the aortic graft up to the aorta, performed a second procedure in 24 hours with a good result this time. But to be honest, I think that this is something that could have been avoided if we had used a better imaging on the first time. And this is again an example of cases that go south because we're not careful enough during the first procedure. And this is something that Peter also mentioned about the serrap reconstruction. So to conclude, TLR is not very common following aortic reconstruction. We know from our studies that we have a benefit when we use covered reconstructions, but we have to plan our procedures very carefully to avoid all these salvage procedures. Many of them will have a very good acute angiographic result, but they will go south on the long term. The introduction of new technologies, both regarding treatment and imaging, might further improve the outcomes of vascular therapy, and I think that both open surgery and hybrid treatment can be very valuable also as salvage procedure after endovascular repair. Thank you very much.
Thank you, Konstantinos. We'll take questions at the end, yes. If I may. No, Mike. Well, Peter, are you still on the? Are you still with us? Can we go back?
I'm still here. I'm still here.
And Konstantinos, can you come? Can you come up and perhaps join us, and we can give you a microphone and everything? Well, Peter, if I can start. Last session, there was a question to Hani Zaid about dissection. If you're going with a retrograde femoral axis and dissection to the level of the renal arteries and so on, what's your experience with re-entry devices, and how can you avoid dissection? What sort of tips you could give us?
First of all, I try to never go higher than, let's say, max 2 centimeters above the aortic bifurcation. If I see that the wire is going higher than that, then I try to either find another way, or if it's possible, go from brachial. Yeah. So sometimes even with a 4 or a 5 French sheet, you can actually perform a recanalization, yeah, and then you go superintimally from above into the common iliac, and then then it's easier and also safer to find or to connect both lumens together. Also, what I try to avoid is when I'm not sure that I'm, let's say, intraluminal in the aortic bifurcation or in the distal aorta, I try to avoid to put in contrast, and especially because in my first year, I just made the decision to try to find out where I was, and I didn't saw that we actually were connected to the angio pump, and we tried to make an angio with a huge dissection as a result. So I try to be as resilient as possible.
Thank you.
In case you can't, there's no brachial access available, or you're not able to go in from either side, then what we mostly use is an outback, or If you have a Pioneer, it's even more safe to use a Pioneer because you have the direction with ultrasound where to go. Yeah, but even with an Outback or a Pioneer, it's sometimes very difficult to go inside with 2 lumen. Another possibility could be if you have a brachial access and it's not possible to enter, is to put a balloon in the distal part, or coming, if the other contralateral iliac is open, you put in a balloon and you try to puncture the balloon with the Outback. So that's much safer than puncture without knowing what to puncture at that level.
Thank you.
So that's a few solutions.
We've got another question for you. One of the cases you've shown us had an SMA stenosis, and you used the chimney CRAB for that. If we got you right, is that right? SMA stenosis rather than treating.
What I meant is that if you have an SMA stenosis and or you have a large IMA, yeah, then I think the best solution is to put in a chimney, and of course treat the SMA if possible. Yeah? Okay. It's sometimes not completely possible to treat the SMA, or sometimes you see that the SMA is as diseased, yeah, with a good or a big IMA. And then when you want to treat the autoiliac lesion, yeah, you probably would cover the IMA. Then you can actually suppose that this will actually trigger some ischemia of the intra-abdominal organs.
Thank you. Well, I have a couple of questions for Konstantinos now. The first is from Hani Zaid. Do you routinely use any quality control imaging at the end of endovascular autoiliac reconstruction?
Not always. So it depends on the lesion. When we have calcified disease, for sure, we will go for IVUS, and especially when we have concerns regarding the opening of the stent grafts whatsoever. So for a very excessive disease, for sure, we'll go for IVUS, especially for CTOs. But if we just have stenotic disease, then probably will not use any IVUS at the end of the procedure. But what we do for complicated disease, that we, after the procedure, we always do a CT scan, just like the EVAR.
Thank you. One last question for both of you before we move on to Professor Schneider. Professor Schneider, shall we do one more question so that you can, yeah? So one more question to both of you is in relation to the cost effectiveness of CRAB and this endovascular modality after what we've heard in terms of failures and the difficulty and the challenges in management of failures, particularly when we're talking about claudicants. I take it many of your patients are claudicants, aren't they? So has anybody looked at the cost effectiveness of CRAB in this group of patients? Worthwhile doing or not?
So in order to perform a cost effectiveness analysis, we need data from randomized controlled trials, and then there will be again specific for every healthcare system. So it's very difficult to perform an overall cost effectiveness analysis. The question is if this kind of reconstructions reduce the need for TLRs, because a TLR can also be a very expensive procedure. If you perform a CRAB and then you know that you have a less risk for a reintervention, which can be a very costly procedure, then I think that this is an argument to use CRAB, even though it's more expensive than a standard procedure. But this is something very hypothetical because we don't have any data about cost effectiveness.
Well, there are models on how to generate this sort of data outside of randomized controlled trials. Otherwise, we wouldn't have been able to generate all sorts of financial data on all sorts of procedures. But Peter, do you have a last comment on that? Or?
Yeah, I think just take in account the hospital stay, yeah, performing a CRAB or a traditional autoiliac bifurcation procedure. I don't know the costs of every country-wise, but here in Belgium, the cost of the hospital stay, the difference is already paid, the material cost. So I think you have to take everything in account. Also, when you put in an autobifemoral graft in a patient that is not so good, and he needed afterwards ICU, and then a week or two hospital stay, or that patient could be treated with a syrup without ICU and a few days hospital, then I think the cost will be directly less or in favor to the endovascular.
Of course, if things all go well, of course. So it's all down to patient selection, isn't it? Well, thank you both. Thank you very much, both of you. We can now move on to Professor Schneider. I hope you've got the right talk now.
I think so. Somehow it got deleted from the system. Hi, Peter. Peter
Hi,
Schneider
Peter.
here. Good to see you. I had fun visiting your lab one time many years ago.
Yeah.
So, anyways, we'll go on to the to this talk. It's going to switch gears a little. We've mostly been talking about aortoiliac disease, and most of what's included in this next talk is regarding BTK disease and CLI. Can we have the talk, please? Okay, so innovative tools on the horizon for the treatment of critical limb ischemia. As I was mentioning, this is an excellent time to be a vascular doctor because I see a real change in what we can offer patients that have critical limb ischemia in the near future. There are a lot of tools on the horizon, some of which are already making their way into practice. But what's represented on this slide is various measures, different methods of measuring hemodynamics. And most of these are not clinically available yet, but there are a variety of methods that are in the works, including on the lower right-hand side of the slide, even the idea of an injectable hydrogel that's dissolved into, it's a microchip dissolved into a hydrogel that then is injected into the foot, and at any time the perfusion needs assessment, you can wave a monitor over the sensor and understand what the foot perfusion is. But think about how many things we do essentially blindly in our practices. We have a clinical impression based on many years of experience of the temperature and the color of the foot and what the angiogram looks like. And we're right most of the time, 80%, 90% of the time. If you incorporate duplex into your, during the procedure, then you can be right even more often. But the truth is, day to day, we make lots and lots of decisions without any hemodynamic measurement. These things need to be validated, quantified, and correlated clinically. But I see in our near future the ability to get moment-to-moment assessments rather than the way we do it now. There's also the potential to do the same type of thing for wounds. So this is provided by a company in the United States in Virginia. And what this is it's like essentially a camera in an iPad. But what it allows you to do is when you take a photo of a wound, to compare it immediately to this same patient over a period of time in terms of depth and width of the wound, but also to compare it to literally tens of thousands of other wounds at the same time and give you a sense of how this wound is faring, getting better, worse, and what the quality of the wound is. Again, we do all this by clinical judgment, and we do it all very often changing observers as we go. If your colleague takes a look and they're describing the wound, it's totally different to have a situation where you could document it. We have some new methods of angioplasty. Shockwave was mentioned yesterday, the potential to use lithoplasty energy to break up calcium. Also, serration angioplasty is something on the horizon. It's a limited release in the United States at the present time. And could you advance the slide for me, please? So what about drug-coated balloons? Well, we had already a very nice discussion yesterday by Jan Gafik about below-the-knee drug-coated balloons, but we have had 3 failed trials of paclitaxel for below-the-knee DCBs. There are several sirolimus DCBs on the horizon. One is Med Alliance that uses a nanoencapsulation in order to deliver the sirolimus. Another one is seen here. This is Concept Medical that puts the sirolimus into a phospholipid and then it's absorbed. And keep in mind that Lima's drugs, although they're cytostatic rather than cytotoxic, it's very challenging to have a broad and complete absorption of sirolimus analogs into the arterial wall. They're successful when delivered by stent, at least in the coronary and other applications, but not so easily by direct balloon application. There's also a US-based company, Surmodics, that has done a first-in-human using yet another sirolimus preparation for BTK DCB, and this will be presented this year at the VEITH meeting. Could you advance the slide, please? There are two paclitaxel-coated DCBs that are also on the horizon, one from Medtronic that has done a first-in-human study in Europe, and you can see the results there on the left-hand side. Also Acotec, which is a paclitaxel DCB from China that's had a primary, or let's say a randomized controlled trial with results out to 6 months, with a big difference between DCB and PTA in terms of primary patency. Nevertheless, this will require a larger study, and we'll see if that data holds up. Advance the slide. There we go. So keep in mind that a lot of the BTK DCB data that we have, although it's preliminary, there's also a concurrent effort going on in the coronaries. And I'm not a cardiologist, but I follow this because it's actually quite advanced, especially in comparison to where we are with BTK DCBs. And so what you see on the top of the slide are the paclitaxel preparations. On the bottom are the sirolimus preparations. And these are the studies, randomized controlled trials in the coronaries, the upper ones being for in-stent restenosis, most of which were quite successful. The lower panel shows randomized controlled trials for small vessel disease. And the results are not quite as clear in the coronaries in that sense. But the fact that this parallel effort is going on in the coronaries, I think, is really going to help us ultimately to get a potential to have a BTK DCB. There's also the potential to do focal dissection repair using the TAC endovascular system. This is a device product owned by Philips. And you can see on the left-hand panel the idea that after angioplasty dissection, at least some of the time is inevitable, and the potential then to treat dissections in a very focal manner with leaving the minimum amount of scaffold behind. And this is a subject of a talk I'll give later. The Saval trial has enrolled. This is a paclitaxel-coated self-expanding stent for below the knee. This is a trial that has been enrolled in the US. And think of it as a small version of Eluvia. And we'll see what the results are. It's gone on to a phase B enrollment now, which I think will be very interesting. The Esprit bioabsorbable drug-eluting vascular scaffold is enrolling also Life BTK randomized controlled trial, 2-to-1 Esprit versus PTA. This trial is also enrolling, and this, of course, was based on favorable data from Singapore and Sydney. This is courtesy of Ramon Varco, and this is published now, showing excellent primary patency out to 4 years. There are also two other drug-eluting bioabsorbable vascular scaffolds, R3 Vascular and Riva Medical. It's early for both, but keep in mind that if we know about two other startups, there are probably 2 or 3 others that we haven't yet heard about. So I think within a few years, this should be a very crowded field. Below the ankle angioplasty. So, I mean, one way to think of below the ankle angioplasty is as an extension of what we already do in the below the knee arteries. But we've never done this before. I have the occasional case from many years back, but think about the entirety of the patient population, the increasing prevalence of pedal artery disease, the fact that we have very limited tools, and then it really starts to look like a true innovation if we can understand and perfect below the ankle angioplasty, I think it could lead to a very bright future. On the other hand, we don't know really what the patency is. There have been no angiographic follow-ups that I'm aware of. It's not an area where it's so easy to understand what the patency is using non-invasive methods. Could you advance the slide? There we go. So there have been 2 studies, one from Turkey, one from Japan. The Rendezvous Registry is probably the largest. And this indicates in patients who had a below the ankle angioplasty added to their BTK angioplasty, that wound healing was faster. However, this is really, even though this is a sizable registry, this is very preliminary, considering that we don't have any patency data that go with it and that it's not randomized. We also have deep vein arterialization. We're going to be talking about this later today, but this is a whole area for development, which is right in front of us. We're right on the threshold of it and the cusp of it at the present time. And then there's also the potential for remote monitoring using wearables and implantables. This is a little bit further ahead, a little bit farther into the future. In the upper left, what you see is essentially a patent application for a stent with a microchip on it. Imagine if you could monitor all your lower extremity interventions by the way the airlines monitor the airline engines. It's all by remote control so that you know when maintenance needs to be done, or at least when the usual maintenance schedule needs to be interrupted or sped up. This would be an awesome possibility if this were possible. And on the lower panel, what you see is a wearable that'll detect all kinds of heart rates and heart rhythms. And here's just an example of the use of wearables. In this case, to look at the effect of physical frailty on major adverse events after lower extremity revascularization. You know, the truth is our patients come in for 10 minutes, we sit them down, we talk to them, and we try to get an impression of what they're actually doing and how they're actually doing. But with a wearable, that would completely change. And then lastly, I would say, you know, my iPhone has 1 billion transistors in it, and yet I'm still doing my procedures using 2-dimensional images and plain fluoroscopy, the same as it was done 40 years ago. Eventually, you know, we will have a GPS like we have when we get on the road in our automobile. We will have that to get to our target lesion. Now, I don't know when that'll be. It feels like it's farther away, but gosh, I wouldn't go anywhere complicated in my automobile without my GPS. So, and then lastly, we've heard a lot over the last 2 decades about genomics, and it's taken forever to filter down to the point where it's going to have an impact in vascular disease. But I just wanted to let you know that numerous different aspects of genomics for PAD, for coronary artery disease, and large artery stroke, you can see there's a Venn diagram there of various locations on the genome that have a profound effect on that. And then on the lower left, what you see is the cost of sequencing the human genome, which is dropping dramatically. So imagine when your patient comes in addition to getting a CTA, you sequence their genome, and you actually get them on the correct medications for what they have, and think about their natural history with more information. So in conclusion, we're looking at lots of opportunities and advancements in patient assessment, different methods of reconstruction, including excitable things like DVA, wearables, implantables, and genomics. So thank you very much for your time.
Professor Schneider, thank you very much. The future is bright, I think, Professor Schneider. Do you care to answer a question or two?
Oh, sure.
Yeah.
I already did my best to mess up the schedule, so I just
want
to make sure
we'll give you one question.
No, you know what had happened was I turned my slides in with fewer slides, so that I would be sure to be on time. And of course, it somehow canceled this last one.
No, it's all well. We actually enjoyed this talk. Thank you very much for introducing us to all these sorts of advances. And I'm trying to. The question was about bioabsorbable stents for BTK lesions and whether they would be effective contrary to the same types of stents in coronary. Yeah, so that was. Do you have any experience
it's a
with
good question.
stents?
Well, keep in mind that it wasn't ineffective in the coronary. It just wasn't as effective. There was a slightly higher rate of MAE with Esprit than there was with the usual drug-eluting coronary stent. So I think the idea I think the reason why this was taken up again now and applied to the BTK arteries is that the coronary arteries, when you put in a bioabsorbable vascular scaffold conceptually, it's great. But I don't think there's any significant downside to having a balloon expandable metal stent that's drug-eluting in the coronary. Whereas below the knee, there's a big downside to a balloon expandable, stiff, rigid scaffold below the knee. You don't get to do ABIs on that patient ever again, for example. And so the idea, I think, of bioabsorbability is even probably maybe conceptually more attractive BTK. Yeah. And the results were not that different. They were within a percent or two absolute difference between the two. Just not good enough for coronary, but conceptually maybe very attractive for BTK.
Thank you. I think Professor Taha will allow one more question. You talked about pedal arch angioplasty, and the question is twofold. Do you do that routinely in your practice? And the second question is, oftentimes you see completion angiograms following pedal arch angioplasty beautifully lined up without so much in terms of digital arteries off that pedal arch. Do you face that, and how does that make you feel at the end of the procedure?
Yeah, this is an important issue, and I think this is probably a better question for Dr. Graziani, since he's, this is something he's thought a lot about, maybe more than most of us. But my own opinion is this, that I think you can get a beautiful acute result with pedal angioplasty, but we don't know. What we don't know is, are we initiating a cycle of inflammation that ultimately makes things worse? That's one. Two, if you go subintimal, you can lose all the branches. And I think that's a scary proposition because you actually can make things worse. And I think the third thing is that if you do get a severe dissection or some other flow-limiting effect, we have no bailout in the small tortuous arteries of the foot.
Thank you very much indeed. At the end of this session, I would like to thank all the speakers and Peter Govid in Belgium, and I'm handing the session to Professor Taha for the next one. Thank you.